This is part 6. In this part, I am going to present general guidelines in the management of keratoconus. Although they are general guidelines, but they should be considered as the basic by which the management plan can be understood. In this part, I will talk about treatment options and the parameters that affect decision making. Good luck. In this part, I'm going to talk about the new algorithm and systematic approach. Let's start with the options available to treat keratoconus. We have glasses, contact lenses, corneal cross-linking. Corneal cross-linking in addition to some types of photorefractive surgery, intracorneal rings, Myoring augmented by corneal cross-linking, Phakic IOLs, and corneal grafting. Now, let's go with some details and sub-options. So we have glasses, contact lenses. There are 3 types of contact lenses that can be used in keratoconus, like soft, toric soft, of course, in the very early stage of keratoconus. We have the hard or gas permeable and the hybrid. Corneal cross-linking has 4 main types: the standard, the hypotonic, the accelerated, and transepithelial. Some kinds of refractive surgery can be added to corneal cross-linking in order to correct some amount of the refractive error in early to moderate stages of keratoconus. We have PTK, PRK, wavefront guided PRK, and LASIK X. Regarding intracorneal rings, we have 3 types. I'm not going to talk about the brand names, but according to the diameter, we have 5 mm, 6 mm, and 7 mm. In regard with Myoring with corneal cross-linking, there are also some sizes, and all these options will be discussed in details later in later parts. Regarding the Phakic IOL, we have the types that are implanted in the anterior chamber and the types that are implanted in the posterior chamber. Finally, we have corneal grafting, including lamellar keratoplasty, penetrating keratoplasty, pachymetry-assisted lamellar keratoplasty, and sometimes we use corneal cross-linking in addition to corneal grafting in order to strengthen the edges of the host cornea for sutures and for better fixation of the graft. Let's talk now about the parameters that have a great impact on the decision making in keratoconus management. We have transparency of the cornea, Vogt's striae, progression of the disease, age of the patient, patient's gender, corneal thickness, maximum K readings, corrected distance visual acuity, the difference between corrected and uncorrected distance visual acuity, and finally, refraction. Starting with transparency. When the cornea is transparent, all options can be available. We can do any of these options. While when the cornea is not transparent because of scars, the only option, almost the only option we have is corneal grafting. When the patient has vox striae, limited options can be available, like contact lenses, Myoring, Phakic IOLs, and corneal grafting. Coming to progression. There are several progression criteria that should be considered in order to decide whether the case is progressive or not. We should not depend on only one parameter. There are several parameters, and we have to observe the cornea on a 6-month period. In addition, we have to use the same topographer. Suppose we are using Pentacam. When the patient comes after 6 months, we have to recapture him by the Pentacam again. And if the patient comes to our clinic with some pictures by another machine that we don't have, we cannot say that, okay, we will capture or see the cornea by our machine, and then we will compare the parameters on our machine with those of the pictures of another machine. We cannot do this. We have to decide on only one topographer. And as you see here, we have several parameters. At least there should be changes in 3 of these 6 parameters over 6 months period. When the case is progressive, then all options are available. And the keystone of the management is the corneal cross-linking to stop the progression. But when the case is not progressive, then the cross-linking, there is no mean to use cross-linking unless we want to do some types of refractive surgery augmented by the cross-linking, or to implant Myoring augmented by corneal cross-linking. Otherwise, if the case is not progressive, there is no need to do corneal cross-linking by itself. Age of the patient has its impact as well. When the patient is younger than 20-year-old, then the best options are glasses, corneal cross-linking, and grafting. Now, the corneal cross-linking is also a keystone in this age because keratoconus is considered progressive when the patient is younger than 20-year-old. When the patient is between 20 and 30-year-old, all options are available. But when the patient is older than 30-year-old, corneal cross-linking is questionable. Why? Because keratoconus in this age has to be documented before considering corneal cross-linking as a treatment. Patient's gender also affects the decision, because we know the hormonal issue in females. Keratoconus can have more progression rate in females, especially in due to pregnancy, and when the female has been cross-linked before pregnancy, her cross-linking may be prone to failure. And also, we have to know from the female if she is planning for multiple pregnancies. Corneal thickness. When the cornea is thin, we have 4 options: glasses, contact lenses, phakic IOLs, and corneal grafting. But when the cornea is thick, then all options are suitable. Regarding K readings, when the K readings are high, then we cannot consider glasses and we cannot consider refractive surgery augmented by corneal cross-linking. And when the K readings are low, then we should not consider Myoring, because Myoring are suitable in cases of very high K readings. And also we cannot consider the lamellar keratoplasty in low K readings, or corneal grafting in general. Regarding corrected visual acuity and the difference between corrected and uncorrected visual acuity, when we have good visual acuity in general, then there is no need to do corneal grafting. And when the visual acuity is bad, we have to exclude glasses, corneal cross-linking, and phakic IOLs. When the refraction is high, then we have to exclude glasses, and we have to exclude photorefractive surgeries augmented by corneal cross-linking. But when the refraction is low, then we have to exclude Myoring, phakic IOLs, and corneal grafting. Now, let's go in some details in these options. Starting with glasses, there are 4 parameters that affect the decision of glasses. When the corrected distance visual acuity is better than 0.6 decimal, they are appropriate. And when the visual acuity is between 0.4 and 0.6, using glasses is questionable. And of course, when visual acuity is bad, less than 0.4, so glasses are not considered. When the difference between corrected and uncorrected visual acuity is more than 2 lines decimal, then using glasses is reasonable. Now, high order aberrations, because in keratoconus, the main problem is the coma and other high order aberrations. When the RMS of the patient is more than 0.37 diopter, then or let's say start with less than 0.37 diopter, then using glasses is reasonable. But between 0.37 and 0.5, it is questionable, while when the patient has high order aberrations, then maybe using glasses will increase the symptoms related to high order aberrations. Regarding refraction, when the refraction is low, using glasses is reasonable. When the refraction is moderate, it is questionable. But when the refraction is high, using glasses is not reasonable. Coming to contact lenses, when visual acuity is less than 0.6, then using contact lenses is better than using glasses. And also, when the difference between the corrected and uncorrected is less than 2 lines, then using contact lenses is reasonable. Also, when the high order aberrations are high and when the refraction is high, using contact lenses is reasonable. So in other words, we can say contact lenses can be used where glasses cannot be. Corneal cross-linking. Of course, it is used when the case is progressive and documented that it is progressive. Also, the age, when the patient is under 20, no need to document progression. We have to go for corneal cross-linking if it is indicated for other reasons also. Now, when the patient is between 20 and 30, either the case is progressive, so we have to go for cross-linking, or we want to do corneal cross-linking with some types of photorefractive surgeries such as PRK. But when the patient is over 30, we have to document progression in order to say that he needs corneal cross-linking, or in some special cases like PMD. As we know that PMD comes in older ages than keratoconus, and PMD is always progressive regardless of the age. So when we have PMD, we have to use corneal cross-linking when it is indicated for other reasons also. And also after 30-year-old, when we want to do corneal cross-linking plus some kinds of photorefractive surgeries. But we have to be careful about the K reading, because when the K reading is above 58 diopters, it has been documented that corneal cross-linking may have some high rate of failure. And when the K readings are over 60 diopters, the rate of complications is high. And of course, the safety margin of corneal cross-linking is very important. When the thinnest location is higher than 400 microns, we can use the isotonic. When it is between 370 and 400, we can use the hypotonic. But less than 370, we cannot use the corneal cross-linking. We cannot go for corneal cross-linking. In addition, we cannot go for corneal cross-linking when we have corneal scars also. Intracorneal rings. Transparency, Vogt's striae, K readings, thickness of the cornea all affect the decision for intracorneal rings. When we have, now I'm talking about the segments, not the Myoring. When we have some scars, when we have Vogt's striae, there is no need to use the ICR because of high failure, because of no effect, and sometimes because of adverse effects. Also, the K readings, we have to consider K readings. When K readings is less than 55 diopters, there is a high rate of success, while when it is between 55 and 60, it is questionable, and when it is above 60, don't use intracorneal rings. The thinnest location also should be considered. When the thickness is less than 350, don't use intracorneal rings. When it is between 350 and 400, it is questionable. I mean that we can use them in very limited cases, but when the case or the thickness is more than 400 at the thinnest location, then we will have very high success rate. Now comes the Myoring. The Myoring also cannot be used when there is a scar, while it can be used or it is indicated when we have Vogt striae. We have to consider K readings when we indicate Myoring. The K readings should be above 55 diopters. Why? Because the Myoring has a very high effect on K reading. The Myoring reduces the K readings by about 10 diopters. So when the K readings are less than 55 diopters, then we are going to flatten the cornea, and this should be avoided. Myoring should not be implanted when the thinnest location is less than 380. Finally, coming to phakic IOLs. There are three things that should be considered. Is the case stable or progressive? This is one question. What about the spherical equivalent? Is it low to moderate or high? And what about the corrected distance visual acuity? Is it unreasonable or reasonable? Now, the best condition where we can implant phakic IOL is when the case is stable, the refractive error is high, and the corrected visual acuity is reasonable. Otherwise, we can use phakic IOLs, but in addition to other options like, bioptics, like we can do corneal cross-linking first if the case is progressive, and then at least 6 months or maybe 1 year, we can do phakic IOL implantation. And sometimes we do intracorneal rings in order to regularize the surface of the cornea and to improve the unreasonable corrected visual acuity. Then we can treat the high refractive error by implanting the phakic IOL. So in other words, phakic IOL alone, the best situation to do this option is when the case is stable, the spherical equivalent is high, and the visual acuity is reasonable. So in summary, the higher the maximum K readings, the more invasive the options will be. The thinner the cornea, the more invasive the options will be. The higher the refractive error, the more invasive the options will be. And the less good corrected visual acuity, the more invasive options will be. Thank you very much. Thank you for listening. In the coming parts, I will start discussing all management modalities one by one. All will be discussed in terms of indications, contraindications, considerations, conditions, and tips and pearls in the management. I will start in the next part with corneal cross-linking. Goodbye.